Hello.
Hi, how are you, Dr. Gopal?
Great. Welcome to another session of Zooming Through ID with Dr. Gopal. I am Dr. Gopal, infectious disease physician in the South Florida. I trained at Duke University and I've been practicing for almost 20 years now. Broward system is one of the largest hospital system in the country. I chair the stewardship program for the four hospitals in the Broward. I am the APD for the fellowship program, infectious disease program. When internal medicine residents rotate with me, I mean, they pick a topic of interest and they research about it. And Zooming through ID is a series where they can showcase what they have learned and they will teach you. So today I have Scott with me, and he's wonderful. He's going to talk to you all.
Okay, thank you very much. And I'll share the screen now. Okay. Everything looks good on your end?
Yes, everything looks fantastic. Yeah. Okay.
Perfect. So we're going to go over candidiasis today. So really for the most part, with candidiasis, it usually is going to be something that is more of a localized infection on the skin. Sometimes there's even instances where it'll be able to penetrate that barrier and then get within the blood itself. And that's when we can start calling it candidemia. And it's actually one of the most common healthcare infections that are associated with these bloodstream infections that we have in our hospitals. And oftentimes, with that bacteria, or not bacteria, candidemia, it leads up to almost 50% mortality rate in hospital systems. And then on the image there, it kind of shows the general picture of what it would look like on patients, as well as how sometimes it gets inside through foreign bodies. So really with the pathophysiology of candidiasis, it often comes from an imbalance of local flora, so sometimes triggered by antibiotics. It could also be from surgical interventions. And with that overgrowth, it often will lead to the localized infections. With the mucosal infections, you'll often notice patients have white plaques such as oral thrush, or sometimes they can even have oropharyngeal candidiasis as well, and coming in with, uh, some throat discomfort, as well as sometimes also having um, some GI bleeding as well. And with the cutaneous infections, these ones are more of like erythematic patches, often with satellite lesions, which helps to define the disease itself, often seen along the mammary areas, as well as the intratracheous skin folds, and often seen on infants as well with the diaper dermatitis. And with most of our elderly patients, we're seeing a lot of the onychomycosis as well. Now, with the more serious invasive infections, once it's able to breach that skin or mucosal barrier, it then will start to, go through different organ systems, and based on which organs are infected, you'll start to notice those signs and symptoms there. And so, really, for the most part, when you have this candidemia, you got to be really careful about any neurological deficits or major organ damage like vision changes and sepsis. And so these are some more images here. So on the far left with the oral thrush, you can see the distinct white plaques there on the soft palate. And then in the middle, you can see the intertracheous skin infections, and you can see the satellite as well, with the small red lesions separated from the main lesion itself. And then on an image on the right, you can see the Candida esophagitis. Oftentimes, you're going to see this mostly in HIV patients uh, as well. So when it comes to diagnosing it, it's usually a clinical diagnosis. It doesn't really require confirmatory testing because of how it really appears on patients. But if you want to, you could do the KOH test as well to confirm the candidiasis on whether it's in the vulvovaginal area, the oral area, or in tragus skin scrapings, or even on from toenail scrapings as well. And then to confirm the susceptibilities, you could get cultures from tissues to rule out, to make sure that it's not truly a bacterial infection like intertrigo. And then with blood tests, once you see something like esophageal candidiasis, you want to do HIV testing if the patient's not already known or suspected to have HIV, because oftentimes they go together with one another. Um, and then usually what you'll see if you do any type of biopsies, you'll see fungal spores, the pseudohyphae, and then oftentimes a neutrophil predominatory inflammatory reaction. So as you can see on the gram stain here on the right side, you can see the pseudohyphae there. Now, when it comes to the cultures, they're often very expensive and not really done very often. And for the most part, because it takes so long to come back, they have very low sensitivity. So oftentimes we just empirically treat this. Same with tissue biopsies, also very expensive. And really, for the most part, we try to rely on just the clinical diagnosis, but you do have options with like the beta D glucan assays as well as the PCR testing as well. The one benefit there is that when you do the PCR, it's very sensitive and specific, and it can kind of help to navigate if you feel like you need to go down a longer road of antifungals. When it comes to the management, so if it's non-invasive, such as the vulvovaginal candidiasis, you could do topical azoles for 3 to 14 days, such as clotrimazole or meconazole. And if it's a non-pregnant patient, systemic treatments, usually with a single dose of oral fluconazole, is okay. If you have oropharyngeal candidiasis, topical nystatin. We also have the swish and swallow Broward, and then you can also do clotrimazole as well, slowly dissolved within the mouth for more pediatric populations. And if it becomes systemic, then you're going to be wanting to go to fluconazole. You could do oral or IV based on the severity of the patient, and oftentimes is for 1 to 2 weeks, especially if it becomes within the bloodstream itself. And then for esophageal candidiasis, first line is going to be the fluconazole for 2 to 3 weeks, and then you could use the second line if it's not responsive, such as the echokinins or amphotericin B. With the mammary candidiasis, oftentimes you need to treat both the mom and the infants with topical, and you could use meconazole for the mom and nystatin for the baby. And it's okay to continue on breastfeeding during this time. With intertrigo or superinfections, we would use topical nystatin, or we can use an azole such as clotrimazole, and we try to protect the skin area because oftentimes they like going in moist places, so adding on drying agents can help to prevent further spread. And with infection of the nail or onychomycosis, topical ciproperox or systemic fluconazoles can work as well. When it comes to invasive candidiasis, especially with bloodstream infections like candidemia, it's always good to have infectious disease on board because these are going to be patients that are going to be very sick and very easily can start to deteriorate very quickly. So it's important, just like with any bacterial infection within the bloodstream, to remove essential ions, Foleys, or any infected prosthetics that the patients may have, and to start immediate empiric therapy. For this, the first line is usually going to be the echokinins, and then second line being the fluconazoles if they're not responding well, or you could even use the amphotericin B. And if it becomes more of a focal invasive infection, getting within to the tissue itself, then it's also good to be using similar things like amphotericin B, as well as the icosapent. The fluconazoles are more for the non-invasive management of candidiasis. And if you're expecting endocarditis, then it's always good to be getting echocardiograms and then making sure that if there's any neurological findings and you're worried about meningitis, that you start with amphotericin B and flucytosine. When it comes to the complications of it, there are many depending on which organ systems mostly being affected. Could range from as severe as meningitis to an abscess within the lung, or oftentimes you can notice it can get within the bone and cause osteomyelitis. So with the superficial infections, you're mostly going to be seeing people complaining of pain, some itching, burning around the sites, and usually just annoying the patient, causing that poor quality of life. Whereas with more of the invasive candidiasis, it can cause sepsis and shock and be very severe to the patient, leading to endocarditis, pneumonias, renal failures. Often there's possibilities of blindness and neurological deficits. And for the mainline treatments, we have our azoles. So for these, at least, with them going after the 14-alpha demethylase, they help to stop the synthesis, at least, of the membrane for the fungal. And then you have to worry about hepatotoxicity, so it's good to make sure the patients don't have cirrhosis, and that if they have any QT prolongation on their admission EKGs, to make sure you stay on top of that, just so that way you know you're not going to be prolonging that QT. For ectokinins, they inhibit the beta glucan synthesis to stop the cell wall from growing. People here with flushing, as it sometimes can release histamine, as well as the same thing with the hepatotoxicity and GI upsets. For amphotericin B, this one's very toxic, so you have to be very careful and monitor the patients closely with this one. It'll bind to ergosterol within the cell membrane and help to form pores and cause cell lysis. It's very toxic to the kidneys. Can sometimes even lead to acute renal failure, hypokalemia, and other electrolyte abnormalities. Sometimes people refer to it almost as like a shake and bake, where they may have fevers and chills. And then you have to also make sure you're watching the cell lines as well, in case there's any bone marrow suppression to worry about. With the flucytosine, it will inhibit the DNA and RNA, and it's often used alongside the amphotericin B. And same thing, you need to worry about the bone marrow suppression and renal failure as well. So keeping an eye on the cell lines and urine output will be good for them. And for as much as at the CDC and Infectious Disease Society, they often are asking for preventative strategies with good hand hygiene, environmental cleanliness, antibiotic stewardship, because it's a big portion of how sometimes the flora can be disrupted and lead to these candida infections that could have been prevented, as well as when it comes to invasive devices and making sure that they're inserted cleanly and taken care of properly. And for specific recommendations, really, for the most part, it's just having that good infectious control established at the hospitals and having all the staff up to date on what they need to do for clean practices. And for at-risk populations, you can provide prophylactic antifungal therapy, especially for those who are going under stem cell transplants for bone marrow, and also sometimes in neonates, especially if they're premature. So there's a couple questions here to kind of help. So we have a 40-year-old male, recently diagnosed with HIV, evaluated for a painful mouth lesion. The lesions can be scraped off using tongue blades. Which of the following would be the most likely diagnosis here? Erythroplakia, lichen planus, oral candidiasis, or oral hairy leukoplakia. So for this one here, it would be oral candidiasis, also known as thrush. And the patients often complain of painful swallowing, and when you look into the mouth, you'll see this pretty clear white surface that's easily scrapable with a tongue blade. And so for this here is just another follow-up explanation of the answer itself. The next question is a 37-year-old man evaluated at the hospital for 3 days of fever. He's receiving prolonged parenteral antibiotics through peripherally inserted central catheter, or PICC line, for infective endocarditis. His temperature is 101.5. He has a right brachial PICC site that appears normal, a grade 2 out of 6 diastolic murmur, heard at the left lower sternal border, and the remainder of the physical exam is normal. Blood cultures are growing Candidiasis species. In addition to continuing IV antibiotics, which of the following would be the most appropriate management? So we have continued PICC use, add amphotericin B, we have continued PICC use and add caspofungin, we have remove the PICC line, and we have remove the PICC and add micafungin. So this one here, the answer is D, to remove the PICC line and add micafungin to treat a central line associated fungal bloodstream infection.
I want to take a moment and just briefly, talk. I know you were talking about Candida albicans, but quickly about some other Candida species that, it's very relevant for the boards. Fluconazole resistance is usually seen with other species. Candida krusei is resistant to diflucan, fluconazole. Candida auris is one of the emerging Candida where we do see resistance to fluconazole. Candida glabrata, if you see that, that is always I mean, most of the cases, unless we do sensitivities. At Broward, we are going to start doing sensitivity testing for the blood cultures when we find Candida. Candida hemluniae is another one where you see fluconazole resistance. For in terms of amphotericin B, one species of Candida that you need to be remembering is Candida lusitaniae, that is resistant to ampho B. Candida auris, there has been cases where there is shown resistance. So for Candida auris, the drug of choice, would be to start with echinocandins. Um, yeah. Okay.
Okay, thank you.
Mm-hmm.
So this one here is just more along the lines of the reiteration of making sure you remove infected lines while giving them the antifungal therapy that they require based on the sensitivities and what specifically species of Candida grew. So for the next question, 62-year-old man in the ICU evaluated for fever and chills. He underwent a subtotal colectomy for stage 3 adenocarcinoma of the descending colon 8 days ago. 6 days ago, hospital-acquired pneumonia was diagnosed, and piperacillin tazobactam was initiated. The patient was moved to the ICU. He was improving, but developed increasing fever and hypotension 2 days ago. Repeat blood cultures were obtained, a subclavian catheter was removed, and the tip was cultured. On physical exam today, the temperature was 103.1 degrees Fahrenheit, blood pressure was 115/60, the pulse rate was 108 beats per minute, and respiration was 26 per minute. Crackles are present at the lung bases bilaterally, the surgical wound and non-tender, and bowel sounds are present. The remainder of the examination is unremarkable. Blood culture and catheter tip from the culture are growing 48 hours and showing budding yeast. Which of the following is the most likely cause of the patient's findings? Blastomyces dermatitis, Candida albicans, Cryptococcus neoformans, or Histoplasma capsulatum. So with this patient, he's growing Candidemia, essentially, Candida albicans. And oftentimes what you'll notice for patients like this is that you have to worry about the essential lines becoming infected, especially when they were giving empiric antibiotics for extended periods of time. So for this patient here, especially as you saw with the budding yeast cells, it's usually that is going to be the trigger to make you think that it's Candida albicans for this patient here. And only usually about 40 to 60% of patients can have these positive blood culture tests. And sometimes doing the T2 MRI assays can help to provide that rapid diagnosis for invasive candidal infections. And these are where some of the more expensive fungal tests come in, like the beta-D-glucan assay that we had discussed earlier. Next question is a 28-year-old man hospitalized for a cough, headaches, nausea, and vomiting of 1 week's duration. 2 days ago, he developed a stiff neck. He has otherwise been well and takes no medications. On physical exam, temperature is 100.4 degrees Fahrenheit. Blood pressure is 110/60, and pulse rate is 112 beats per minute. Respirations are 22 per minute. Nuchal rigidity is present. Neurological examination is normal. An abdominal examination reveals hepatosplenomegaly. On his cerebrospinal fluid, the putting pressure was 240. Leukocyte count was 100 with 80% lymphocytes. Glucose was 35 and protein was 155. HIV antibody antigen combination immunoassay is negative. Blood cultures are negative, and cryptococcal serum and cerebrospinal fluid testing is still pending. Cerebrospinal fluid gram stain is what's shown on the image on the right side there. And as you can see, you see some broad-based budding yeast. So which of the following is the most appropriate treatment? Acyclovir, caspofungin, liposomal amphotericin B, and flucytosine, or vancomycin and ceftriaxone. Given that we can see clearly on the gram stain with the budding yeast, it is most likely to treat with antifungals such as amphotericin B and flucytosine, as this is invasive candidal meningitis.
Just a teaching point about the different, antifungal. One of the testing boards, they love to ask about mechanism of action. So azoles, they basically stop the sterol synthesis of cell membrane. Echinocandins, they basically block cell wall synthesis, the glucan fibers. Ampho-B makes cell membrane leaks. And then flucytosine, it blocks the DNA synthesis in nucleus. So those are some of the key mechanism of action. Yeah.
Perfect. Thank you. Thank you.
Mhm.
Okay. Next question is a 48-year-old man evaluated in the hospital 5 days after admission for increasing shortness of breath, productive cough, pleuritic chest pain, fever, and chills. Medical history is notable for acute myelogenous leukemia, for which he was receiving chemotherapy. Laboratory studies show a leukocyte count of 200 with 75% neutrophils and 5% bands. Empiric therapy with cefepime and vancomycin was added to previously initiated prophylactic fluconazole. On physical exam, temperature is 102.6 degrees Fahrenheit, blood pressure is 125/60, pulse rate is 128 beats per minute, and respiration rate is 26 per minute. Crackles are heard bilaterally on pulmonary auscultation. Chest radiograph shows bilateral necrotizing bronchopneumonia with multiple nodular and cavitary infiltrates. Chest CT is shown on the right side there. A serum galactomannan assay is positive. Which of the following is the most likely cause of the patient's pneumonia? Aspergillus, Candida albicans, Cryptococcus neoformans, or Histoplasma capsulatum? So for this one here, the answer is Candida albicans, and usually because of the risks that you have to worry about here are especially with the chemotherapy causing the immunodeficiencies. Oh, I'm sorry, I meant to say Aspergillus.
Aspergillosis, yeah.
Yes,
Mhm. Yeah.
sorry. So with the invasive pulmonary aspergillus, it often will invade the pulmonary blood vessels and causing distal infarctions and allowing them to form these fungal balls in the chest. Oftentimes you'll see cavitations later on in life where you could possibly see these fungal balls form.
Candida in the sputum is something that we usually see in the practice. It's usually a colonizer. In the lung, Candida is not that common. But if somebody has thrush, then, if they are on antibiotics, if I see the sputum, with Candida, then I will treat for the thrush. Okay.
Okay. And then, yes, just like what Dr. Gopal was saying, it's rarely going to be producing any infections within the respiratory tract. So really for the summary for Candida albicans and non-invasive versus invasive candidemia, it's important to have early detection for especially invasive infections and consulting ID to help save time and also allow for appropriate management to decrease the chances of resistance and treating appropriately. And just recapping over the non-invasive ones for oral thrush, vaginal, and cutaneous. Usually it's a clinical diagnosis. We often treat with the topical azoles like fluconazole. And then for the invasive candidemias and bloodstream infections, oftentimes we'll try to blood cultures. Although it's only 40 to 60% of the time positive, it is good sometimes to use the more expensive assays like the beta-D glucan assay, and even sometimes having the biopsies with cultures growing there. And usually we treat with the echocandins in this point, unless it's meningitis or more severe, requiring amphotericin B and flucytosine. And just remembering the complications of all the treatment options you have, so that way you can monitor appropriate renal, hepato, and as well as cell lines for any disturbances there. And then these are our references from the ID Society and Boston Up to Date with questions from Mixed.
Okay. It was wonderful presentation. Good job.
Thank you. Thank you.
Okay. So thank you for everyone joining.